Welcome to the mental health video series for people living with diabetes. My name is Candice and I'm from Diabetes Canada. Diabetes distress and depression may look and feel similar, but knowing how they are different will help you get the right care. In this session, we will explore diabetes distress and how it is different from depression, the tools used to make a diagnosis, and strategies that can help with managing your mental health with Dr. Gaurav Mehta, Medical Director of Psychiatry at Southlake Regional Health Centre in Ontario. Dr. Mehta is also one of the co-authors of the 2023 revision of the Mental Health Chapter in Diabetes Canada's Clinical Practice Guidelines. He's the founder of Diabetes Mental Health Clinic at Southlake Regional Health Centre and served as an advisor for the Mental Health and Diabetes Training Program, a partnership between Diabetes Canada and JDRF. Over to you, Dr. Mehta.
Thank you so much for your kind introduction. In this presentation, we'll give an overview of how the diabetes impacts the mental health of a person living with diabetes. We will talk about the diabetes distress concept and the concept of major depressive disorder and what are the differences between them. We'll talk about the screening tools available for diabetes distress as well as major depressive disorder. We'll talk about the various modalities of treatment available for these conditions, whether it's talking therapy or medication or both. Living with diabetes is not easy for a person with diabetes, as the diagnosis and the management of diabetes can be a significant life stressor for people and their families, as it may be associated with challenges regarding the acceptance of the illness and the participation in the treatment. Addressing concerns regarding illness beliefs and participation in treatment recommendations can be helpful. The lived experience of diabetes is often associated with the struggles specific to the illness, and it can lead to significant concerns, specifically diabetes distress, the stigma perpetuation, reluctance to start insulin when recommended by healthcare professionals, and the persistent fear of hypoglycemic episodes. There are well-established psychological reactions when a person is diagnosed first with diabetes. It can be perception about the seriousness of the disease. A person may discount the seriousness of diabetes, which is often seen in patients or people with diabetes, with type 2 diabetes, which are not having any symptoms or asymptomatic type. Or a person may become overwhelmed by the diagnosis, which is often seen in persons with diabetes and their families with type 1 diabetes. Not being able to comprehend the extent to which the diabetes can be managed successfully and the degree of personal responsibility required for the management by the person, and the perceived benefits and the barriers to taking action. Professional support to address these reactions can be helpful in promoting the self-management of diabetes. Stigma associated with diabetes is huge. Weight-based stigma is thought to be of quite value here. The perception and the experience of being discriminated against due to one's body weight can be perpetuated by providers in healthcare settings. And when present, this can lead to worsening distress, diminished quality of life, as well as decreased self-management of diabetes behaviors. It is recommended that healthcare professionals should be aware of their own biases and should be able to communicate in non-stigmatizing language about the weight-related issues and diabetes management. Diabetes comes with a financial burden. It is an expensive illness to live with and to manage well. People living with diabetes should ask their healthcare teams for help, and the healthcare professionals should recognize that the key role they play in accessing financial supports. Advocacy and activism are helpful and often necessary to manage the cost of people living with diabetes. The cost associated with diabetes can be direct as well as indirect. So diabetes distress refers to the negative emotions and the burden of self-management related to living with diabetes. It describes the despondency and the emotional turmoil specifically related to people with diabetes, in particular the need for continual monitoring and treatment persistent concerns about the complications, and the potential erosion of the personal and professional relationships, which is not easy. It can induce the feelings of loss of power, fear, and shame in a person living with diabetes. It is difficult to manage all the changes to the routine appointments or the doctor's appointments or medication compliance. Diabetes distress has received extensive research over last decade by healthcare professionals, and there is a lot of evidence that diabetes distress is common. It can affect approximately 1/3 of people living with diabetes. Risk factors for developing diabetes distress include being younger, being a female, having a lower degree of education, living alone, having a higher BMI or body mass index, lower perceived self efficacy, lower perceived provider support, poor quality of diet, greater perceived impact of glycemic excursions, and a greater number of diabetes complications. A person with type 1 diabetes mellitus has to take approximately 180 healthcare decisions in a day, which is not easy. Diabetes is a costly condition. It is associated with significant direct costs such as medications, diabetes supplies, traveling to physicians and allied healthcare provider appointments, food plans recommended for diabetes. It can also be related with significant indirect costs, such as decreased productivity, management of complications of diabetes, hospitalization related to diabetes. It has been found that treatment participation in diabetes care is affected by these direct as well as indirect costs. Diabetes comes with a package of emotions. The experience of threat, which can cause feelings of anxiety in a person, the experience of loss, which can cause feelings of sadness or depression, the experience of unfairness, which can invoke feelings of anger in a person with diabetes. Major depressive disorder is a mental health condition described in the DSM-5-TR, which consists of either emotional symptoms such as low mood and reduced enjoyment of usual activities, vegetative symptoms such as sleep, appetite, and energy level changes, behavioral symptoms such as agitation or slowing of movements, cognitive symptoms such as poor memory or reduced concentration or guilt feelings, and thoughts of self harm may be seen. So, the prevalence of clinically impactful depressive disorders among people with diabetes is approximately 30%. The prevalence of major depressive disorder is approximately 10%, which is double the overall prevalence in the general population. It is important to remember that the risk of developing major depressive disorder increases the longer a person has had diabetes. The risk factors for developing major depressive disorders in individuals with diabetes are female sex, adolescents or young adults and older adults, lower socioeconomic status, having few or less social supports, stressful life events, instability with glycemic control, particularly the recurrent hypoglycemic episodes, higher illness burden, longer duration of diabetes, and the presence of long-term complications. If a person is experiencing any symptom of distress or major depressive disorder or any health condition, it is recommended to work closely with your healthcare team, talk about your symptoms, the way you feel, and the emotions, share your concerns, and discuss your options for the treatment. Screening is of very high value, particularly in diabetes distress, because it can lead to worse prognosis. Diabetes distress scale in type 1 diabetes consists of 28 items, and there's a diabetes distress scale in type 2 diabetes, which consists of 17 items. In type 1 diabetes mellitus, the diabetes distress scales consider domains such as powerlessness, distress management, eating distress, negative social perceptions, physician distress, and the family or friends distress. In type 2 diabetes, diabetes distress scale consists of measuring emotional burden, physician related distress, regimen related distress, and the interpersonal distress. Also, paid questionnaire is validated as well as the type 1 and type 2 diabetes distress questionnaire. For screening of depression, we use PHQ-9 or the Patient Healthcare Questionnaire for Depression, which consists of 9 items. It is a self-report scale which uses rating from 0 to 3 based on the feelings and the experiences over the past 2 weeks. Anxiety questionnaire is the GAD-7, which consists of 7 questions. They are freely available on internet and they don't cost any money. These scales should be available with your healthcare providers. These are validated tools for clinical as well as research purpose. They are the screening instruments, and the diagnosis can be confirmed by the healthcare providers by doing a detailed assessment following the screening, and they can work with you closely to treat any condition if diagnosed. Treatment can consist of either behavioral therapy or medication or both. For treatment of mild to moderate depression, usually behavioral therapy or treatments are recommended. It may consist of cognitive behavioral therapy. The cognitive component includes record keeping to identify distressing automatic thoughts, understanding the link between the thoughts and the feelings, learning the common thinking errors that mediate distress, like all or nothing thinking, personalization, magnification, minimization, analyzing negative thoughts and promoting more functional ones, identifying basic assumptions about oneself, like unless I'm very successful, my life is not worth living, and being encouraged to adopt healthier ones, like when I'm doing my best, I should be proud of myself. The behavior component includes strategies to help the person moving, like behavioral activation, scheduling pleasant and meaningful events, learning assertive and effective communication skills, focusing on the feelings of mastery and accomplishment, learning problem solving strategies, exposure to new experiences, shaping behaviors by breaking them down into smaller steps to develop skills. Motivational interviewing is to establish a change based relationship that is based on bond, task, and goal alliance. It is to demonstrate the non judgmental curiosity and comfort with ambivalence. It uses the ask, listen, summarize, invite framework to normalize the person's experience, establish a collaboration, seek the person's ideas, and then ask permission to provide the ideas. Acceptance and commitment therapy focuses on the acceptance on the present moment experiences and diffusing from the thoughts, choosing not to be guided by present cognition or the schema of thoughts. Commitment to flexibility in perspectives and determine the committed action based on values. Medications may include antidepressants, which is the most recommended treatment for major depressive disorder. The choices can include SSRI medication or SNRI medication. They work on various receptors in the brain, including serotonin, noradrenaline, and other receptors. Antipsychotic medications may be used in conditions like schizophrenia. Anxiety medications may be used for short-term management of anxiety or even long-term management of anxiety disorders, even panic attacks. Mood stabilizers are used in conditions such as bipolar disorder. Sedatives or sleep aids can be of value. Stimulants such as Medication for ADHD may be helpful for people who have comorbid attention deficit hyperactivity disorder along with diabetes. So the takeaway message is a person with diabetes should expect to have feelings and emotions about diabetes. Person should be able to recognize when it is more than the diabetes distress. Ask to be screened for diabetes distress as well as major depressive disorder or anxiety disorder. Closely work with your healthcare team to find out the best possible help that would work for you.